Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers, and today we're talking about Utah's experiment with artificial intelligence in healthcare. Zach Boyd is the director of the Office of AI Policy in the state of Utah. He's overseeing a program that waives state regulations on certain uses of artificial intelligence for a trial period. He talks to Dr. Josh Sharfstein about the first application in healthcare, an AI program that can refill prescriptions for up to 200 medications. They discuss the origins of this effort, concerns that have been raised inside and outside of Utah, and what's next. Let's listen.
Zach Boyd, it is great to have you on Public Health on Call. How's today going for you?
It's a good day so far.
Excellent. What's the weather out there in Utah?
Well, it started out about 50 this morning. It's supposed to be like 90 by the end of the day, so changing by the minute.
Okay, sounds good. A few other things are changing by the minute. You are the leader of the Office of AI Policy in the state of Utah, and in January, you launched the first state-approved program in the country that allows an AI program to participate in medical decision-making by having artificial intelligence do prescription refills. And that made a lot of news.
Yeah, it was wild. This is a pilot. It's still in the earliest stages. There's full human supervision over everything. But it just seems like, a state entertaining the possibility of this and beginning to gather data on how governance might look has just really captured a lot of people's imagination.
It certainly has. But before we get into the details, I'm interested in how you got here. Tell me a little bit about yourself and the office and what led up to the moment of launching a program like this.
Yeah, so my background is in academia. I'm a mathematician, so done a lot of work in social science modeling, things like computational psychology and stuff like that. And then when ChatGPT came out, the state of Utah just kind of woke up to the fact that there needed to be some rapid policy development in this area. And I got looped in as the AI expert who could interface with the policymakers and try to help the state navigate this big transition.
And where did you start in that job? I mean, what were you thinking?
Well, I don't think anyone knew what a role like this could look like because there wasn't one prior to this. But we kind of got the dual mandate from the top, which is that you want to make sure the state is maintaining its consumer protections and updating them as needed. I think there was a lot of concern about how social media turned out, for example, that maybe the state and most states didn't really have much of a strategy about that for a long time. And then on the other side, there was this idea that there are a lot of industries where we have a ton of rules and it's not really clear how all of them are going to apply to AI. So we just kind of started from there of trying to survey the different needs, and we've landed on a few. The state can't tackle everything at once. So we did mental health, we did deepfakes, we did AI companions, and now we're looking at AI in healthcare.
Those are all really interesting topics. It sounds like we could do like 12 podcasts with you at least. But keeping with the idea of AI in healthcare, how did you land on the idea of prescription refills as the first step forward?
Well, so one of the programs that we operate is just a regulatory sandbox, and that's actually industry driven. So we just maintain an open call. Anyone who has an idea for how to deploy AI in the state that is, where there's no clear regulatory pathway to do so, can apply to this program, and we can make a one-off regulatory exception for them under defined governance standards. And basically, this company, Doctronic, came to us and suggested prescription refills. And so we did a bunch of vetting to determine possible benefits for the state. Eventually, we decided there was a possibility that this could be beneficial and defined a way for it to move forward.
Got it. So tell me more about the program now and what its goal is.
Yeah, so the program is basically designed to give the state regulatory flexibility. The usual regulatory pathway is 1 or 2 years long. And with the rate of change of the technology, it was just thought that the normal pathway would not always be adequate. And so when we receive an application, we're supposed to identify, is there a real regulatory barrier to doing what they want to do, the applicant, the company? Is there a potential benefit for the state? And is there a way we can design the governance in such a way that we can let the company go forward in a way that will generate evidence, generate a more robust knowledge of best practices, and help us move toward a long-term regulatory solution?
So walk me through that 3-step process for this particular idea.
So for the prescription thing, we identified together with the applicant that a process like this could potentially violate the professional conduct laws of the medical practitioners overseeing it. It could potentially violate the unlicensed conduct laws of the AI or the company that the prescription is attributable to. And it could potentially violate some parts of the telehealth law. So there's a barrier. Potential benefit for the state. I mean, we'll see, we're collecting data on this, but the hypothesis was that, medication noncompliance is a serious public health problem. And there's some evidence that this is due to friction in the system. Certainly, some people have reported the process of getting their refills is burdensome or unpleasant. And so, the
And
hypothesis
expensive. We could add in expensive for some people.
and expensive, and especially for our rural population, maybe time consuming. And so, so there was a potential that maybe an AI system could be well received by patients and, increase our public health outcomes. And then in terms of governance, we consulted with a number of healthcare experts, AI experts, public health experts, and basically identified a protocol where we have a 3-stage deployment. In the first stage, there's constant human oversight in the background. In the second stage, you're kind of overseeing the AI like you'd oversee a medical resident with a review of all actions soon after the fact. And then in the third stage, there's some degree of autonomy with regular sampling to ensure continued performance. So right now, it's just in phase 1. And there are a bunch of other safeguards. We published the protocol online.
Got it. That published protocol online's attracted some attention and some concerns from different quarters. I'm sure you're familiar with them. Is it okay if I run through a couple of the questions that have come up?
But yeah.
Well, one is whether you think it will work as intended, just as the AI. In other words, the idea is maybe I'm on blood pressure medicines. I go to the AI and it asks me a few questions and it'll refill my blood pressure medicine. But what if I actually need something different? How do you feel comfortable that patients will get what they actually need?
Yeah, well, this is one of the things that phase 1 is supposed to assess, right? So we've got now, I believe, at least one physician reviewing every chat log after the fact before authorizing anything. So we'll get that. We have independent audit authority. So we just made our request of Doctronic for some data to go through with independent experts, the chat logs, to make sure that, independent experts feel that this is being done correctly. We have agreements for certain things that are not going to be done by the AI system, right? So if a titration is necessary, that should not be done by the system. If a worrisome side effect or a complexity is emerging, then that should also be escalated to a human. So we have different safeguards in place. The idea is to kind of try it in a setting where we would catch serious problems and where we are, even if the system does not perform as intended, the damage would be very, very limited. And then over time, it may prove itself and get some more reach.
And do you anticipate, if you do an independent review, releasing that so people can see the value or challenges that have happened?
Yeah, this is one of the things that we are currently figuring out how to navigate. And honestly, we probably should have put it in the contractual provisions before so we could really force ourselves to think through. That's one thing that's not in the protocol. So our office is receiving this information. We have audit authority. We've told everyone who applies to the sandbox program that our authority from the legislature is limited. We can give people 1 year with possibly up to 2 one-year renewals if we think more time is needed to pilot. And at the end of that time, they have to have garnered enough deserved public trust for the legislature to create a permanent regulatory solution for them. And so, for example, we are already in the process of developing high-level outputs to share with the public. Some things we're not going to share, right? We're not going to share any personal information. We're probably not going to share specific patient outcomes. And we do want to create an environment of candor where the companies can share their failures with us if there's a learning for the state to be had. So we're still figuring out what we can release. Certainly high-level outcomes, diversion rates to humans, physician concordance, those have to be released, and we're working on that soon. But yeah, we're still figuring out what the exact boundaries are there.
Yeah. There's also been the question that's come up about whether by going to an AI to do a renewal, somebody is losing the opportunity to have an interaction with the doctor. Maybe the doctor would notice something on my face and say, you got to have that looked at, or something else. I would share something with the doctor and that would be important for my medical care. How do you all think about that question?
Yeah, I mean, this is one of the hardest ones in any kind of technological healthcare intervention is, you're trying to figure out what you lose when the human element is less intensively involved. I mean, for some people, the human element wouldn't be involved because they might not be getting care. But you're right, there are some people for whom that would be beneficial. Some of the things we've decided for the pilot, at least, is that these are only going to be for renewals for a finite list of chronic conditions. And per medication, there's a stop limitation that you can't have renewed more than X many times without having seen a primary care provider in person or at least via telehealth. So we're trying to limit it that way by at least requiring people to come back to a doctor every so often, but there may be a legitimate kind of continuity of care versus accessibility trade-off here.
So it's sort of like there might be that risk, but there may also be countervailing benefits.
Exactly.
Let me ask you about the question of accountability for errors. It's been reported that when people sign up for this, they're saying, I won't hold the AI responsible if it makes a mistake. Is that a fair description? Do you think there should be accountability? A company comes to you, they want regulatory relief, but if they do something wrong, should they be able to be sued?
Yeah, so this is one thing that I'll share the vision for what we wanted, and then I'll give a little more detail. So, currently in healthcare, there's different layers of accountability already in place. We talked about some of them on professional conduct, professional licensure. Then there's civil and criminal liability in terms of malpractice and things like that. And what we really wanted to do is make sure we tried to leave all the civil and criminal liability unmodified because we think they're really important consumer protections there. And if someone gets hurt, they should have a remedy. It has been reported that at some point, the Doctronic company put in their terms and conditions some disclaimers of liability. That's really recent. I've written to Doctronic asking them to explain themselves. And, this is contrary to the intent of the pilot. So we'll have to get that resolved. But certainly in healthcare, the providers should bear responsibility for their conduct.
Got it. Last question that's come up is the question of regulation, because in your regulatory sandbox, you're waiving the state regulation, right? You're creating this environment for people to try things without a state agency coming in. But there's also the federal government, which, has some thoughts sometimes about regulation. And there's a question about whether or not, even in this case, it's even legal for there to be a prescription without a practitioner who's licensed involved. And I know that this has also created within Utah some opposition from the medical board, which has asked you to stop, I think, if I'm not mistaken, altogether. So how do you think about this question of regulation? Is it just a matter of getting it all out of the way to try something, or is there a role for either the federal government or others within the state at this time?
I guess I wouldn't say that the goal is to get rid of regulation. I think the goal is to develop mature, appropriate regulatory pathways. And right now, there are no really clear regulatory pathways for either autonomous or semi-autonomous healthcare provision. And so I think it is incumbent on the state as a regulator of the practice of medicine to develop appropriate pathways for that sort of thing if it can indeed be done safely. As far as the federal government and the FDA is concerned, sandbox participation at the state level does not change anything about the federal regulatory applicability. So we try not to tell the FDA how to do or not do any part of their job. So that's a different matter. We've not gotten any signal from the FDA that they are concerned or worried about this. There is this interesting overlap that's now happening where there's traditional medical device regulation and then the states handle practice of medicine regulation. And now when there are devices that purport to do, some substantial and probably an increasing load of the practice of medicine, I think there'll be some years where states and federal government are figuring out what they want to do. And I know given your background, you'll have very interesting and mature thoughts on that as well.
Good. Sounds like if you got a letter from the FDA, you wouldn't crumple it up and throw it out. You'd read it. That's what I'm getting from.
No, and we've had some informal conversations, but I don't want to represent them in any way. They'll represent themselves, obviously. And then in terms of locally in Utah, it's been interesting. There are all kinds of different parties that are coming out because this has just gotten a ton of interest. There were some members of the medical board, 11 members of the medical board signed a letter that asked to pause the pilot until they could be consulted further. That was partly an administrative mistake on my part, as well as just not realizing that this was going to get so much attention. We talked to them about the pilot after it had already been signed. They preferred to be talked about before the agreement was signed. My perspective, which is obviously not the same as theirs, is that while we have humans reviewing every decision, it's already within the standard of care for the state. And so it seemed fine until we advanced to phase 2. Given the way that they feel and their role in the state, we've committed to including them before signing any future healthcare-related agreements in the future. On a broader level, we found people coming out from hospital system, public health organizations, Medicaid, all kinds of aspects of the state really interested in this. I would say broadly in the spirit of wanting to be included because they see this as a potential big change down the line for medical regulation. And we welcome that and we want to work together with them.
What have you heard from the general public so far?
I think it's mixed reactions. I would say most people, when they think about this, fall into a few camps. Some say, oh, I wouldn't want to do that because I don't like AI, which is fine. Others say, yeah, prescription renewal is really inconvenient for me, and I would indeed, enjoy a service that's useful. Anecdotally, you'll hear some people saying that one thing they hate about the current system that they work in is how rushed and impersonal it is. Ironically enough, a AI system can feel like it has all the time in the world and, can be personal in different ways, strangely enough. And then multilingual support and just convenience of any time of day are appreciated. But I don't, it's too hard to tell at this point what the average person thinks. We don't have robust random sample data.
Interesting. Have you thought about working with an academic partner to do more formal studies of how it's going, not only from a is it working perspective, but also how people perceive it inside and outside of the program?
That is interesting. I mean, we've talked to a lot of partners at U of U Health, so that's University of Utah Health, who obviously have an academic perspective. They're mostly interested in assessing clinical safety. I would say the closest to what you're talking about is some conversations we've had with the One Utah Health Collaborative, which is kind of strategically responsible for evolving the healthcare system as a whole in the state. And they've offered to give some feedback on where they think the biggest impacts are. But no, I have not heard of anyone just asking sheerly on the public sentiment and perceived value side of this. So that would be really interesting.
There has been a lot of attention to this. Is there anything that you think people have gotten wrong or anything you'd like to, extra clarify about what's out there?
Yeah, I mean, I would say some common misperceptions are that, we've just unleashed the AI. I think that's not true. There has not been a single medical decision that's not been overseen by a human in this state so far. I mean, there may not be for a long time. We're just exploring. It's a pilot. The second thing is, I think, and this your audience will understand this well, a lot of people want to phrase things in terms of absolute safety, which is, of course, important. But I would say for the state context, the two questions are compared to what? In other words, are you getting a relative improvement and for whom? So we're trying to figure out what populations are helped and what the locus of risk is. And then also the state has to think of the healthcare workforce and its utilization. And so the question is, given our scarce expertise, we're trying to assess which parts should be handed off to less skilled humans or to algorithms that may be able to do repetitive tasks better so that the humans can do the most human things that they're really specially trained to do. So those are just a couple of framings that I think, whether you take those framings or not, really affects your opinion on this kind of project by the state.
Well, I really appreciate your time in sharing your perspective, telling us from your side what this is all about. And I hope maybe we'll get a chance to check in and hear more about how it's going.
Yeah, no, thank you for the conversation.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.